The Washington Manual of Surgery podcast is based on the 9th edition of the best-selling Washington Manual of Surgery.
This podcast is meant to condense key topics from our manual into bite-sized episodes for your convenience. Now, on to this installment of the Washington Manual of Surgery podcast.
Hello, everyone, and welcome to the Washington Manual of Surgery podcast. We bring you everything you need to know about high-yield general surgery topics built for your just-in-time learning. Today, we'll be discussing the essentials of the surgical management of obesity. I'm your host, Diego Polanco, and joining us is a distinguished guest, Dr. Egon.
Thank you very much, Diego, and it's great to be here on my very first ever podcast.
Awesome. Dr. Egon is the director of the Adult and Adolescent Bariatric Surgery Program. After earning his medical degree from Harvard, he completed his residency here at WashU and has dedicated his career to bariatric surgery since 1997. He has been instrumental in our designation as a Center of Excellence by the American Society of Metabolic and Bariatric Surgery and has personally helped over 4,500 bariatric patients. Dr. Egon is also a significant contributor to our surgical education as residents. Welcome to the show, Dr. Egon. As most of you know, obesity is a major public health issue that affects millions of individuals worldwide. It is associated with numerous comorbidities from diabetes, hypertension, cardiovascular disease, and various forms of cancer. Surgical management of obesity, also known as bariatric surgery, has been proven to be an effective intervention for achieving significant and sustained weight loss, as well as for improving obesity-related conditions. Well, we'll dive into a case scenario to start discussing the specifics. So, Dr. Egon, we have a 45-year-old female that presents to your clinic with a BMI of 42 and a comorbidities of type 2 diabetes and hypertension. Despite of attempting weight loss through diet and exercise, she has had minimal success. What key information should we gather from her history and physical examination? And what additional tests are important to patient selection and progression through the bariatric surgery process?
Well, Diego, the basic indications for undergoing bariatric surgery are you have to have a body mass index over 40 or a body mass index between 35 and 40 and obesity-related comorbidities such as diabetes, hypertension, or sleep apnea. In addition to that, we really are assessing the patient's capacity to undergo a major general surgical procedure. Now, in addition to that, we have patients evaluated by a psychological counselor and a dietitian to both educate them and to screen them for possible contraindications to surgery. The other thing I think is important to realize when you're evaluating bariatric surgical patients is a lot of times they have undiagnosed or underdiagnosed or undertreated medical comorbidities. So we're really going to be looking at things like do they have undiagnosed diabetes, sleep apnea, hypertension, et cetera.
Okay, after deciding which is a good patient, what are the most common surgical techniques currently used in bariatric surgery, and which one do you use more frequently? Additional or other specific tests we should consider for patients based on the chosen surgery? So
in general, testing that we do for patients, we do H. pylori testing and eradication if they're positive. We have recommended smoking cessation. And then some surgeons do preoperative weight loss, but we don't have a specific weight loss goal in general. Sometimes that's indicated, for instance, patients have extremely high BMIs and we're trying to get them prepared for a laparoscopic approach. We also, again, have patients, we have to, I guess an important part of what you do with these folks is looking at their insurance stipulations, because a lot of them have specific diet plans, medically supervised weight loss plans that have to be done preoperatively in order to pre-authorize them for surgical, for payment for surgery. When we're looking at the surgical procedure choice, once a patient is found to be an appropriate candidate, the main surgical procedures we're really looking at today are laparoscopic gastric bypass, laparoscopic sleeve gastrectomy, and duodenal switch. The lap band was a procedure that was very popular in the early 2000s, early 2010s, but has really fallen out of favor, and really we don't do that operation much anymore. And for us at Washington University, about 60% of our patients end up getting a gastric bypass type of anatomy, about 40% get a sleeve gastrectomy, and 1 or 2% get a duodenal switch type of anatomy.
So what would you say are the difference in weight loss going from one procedure to the other? And what would be the pros and cons of one versus the other?
So a lot these operations have different characteristics on various fields, and among them is weight loss expectation. So the gastric bypass, average weight loss is about 70% of excess body weight. So for instance, for a 6 foot tall person who's 400 pounds, about 200 pounds above ideal body weight, we'd expect that person to lose about 140 pounds at a year to 18 months post-op. The sleeve gastrectomy percent excess weight loss is around 55%. So again, for that 400 pound patient example, they'd lose about 110 pounds. And then the duodenal switch procedure, the average expected weight loss with those is about 80%. So for, again, person 400 pounds, 200 pounds above ideal body weight, they would lose about 160 pounds over the course of a year to 18 months.
Yeah, just to mention that is interesting. Reading about bariatric surgery the first time, when I read the percentages, I thought it was about their whole weight, not just about the excess weight.
Right. Well, that's a great point. And because there's a lot of different kind of outcome measurement parameters that various studies have used. In the medical literature, they tend to use percent total body weight loss, whereas in surgical literature, the tradition has been to use percent excess weight loss. Now, this kind of comes into play when you're looking at the preoperative BMI distribution of your patient population. So if you're starting off with your average BMI preoperatively is 39, those patients are going to lose a much larger percentage of their excess body weight. Whereas if they start off with an average BMI of 50, like our bariatric patients are, they're going to have actually a slightly smaller, lower excess body weight percentage. But in terms of total body weight loss, the gastric bypass loses about 35% total body weight, sleeve gastrectomy around high 20s, 28, 29% total body weight loss.
Okay, so let's go through the technical elements of some of the specific ones. For the sleeve gastrectomy, what are the technical elements that we cannot miss and the anatomic landmarks used to resecting the stomach to create the sleeve?
So with the sleeve gastrectomy, generally we take down the gastroepiploics from a point down near the pylorus, around 5-6 centimeters away, all the way up to and including the short gastric vessels, and then end up dissecting off the left crust of the diaphragm. Then in formation of the sleeve, we'll use a stapling device. And now there's some variation between surgical practices as about what type of stapler that you might use or whether it's a buttress staple line. But typically you'll make that initial transection point around 6 centimeters or so from the pyloric sphincter along the greater curvature, aiming it towards the incisura, but not too close to it. And then I'll typically put a bougie in along the lesser curvature of the stomach to use as a guide for the continuation of that staple line more superiorly. And again, some variation between surgical practices. I use a 40 French bougie in there and then lay that stapler down close to, but not tightly abutting against that bougie as we go up to the angle of His. Again, typically we will do a little pressure test at the end of all that to make sure there's no staple line leak.
A quick question that I have. Talking about staple lines, is there a difference between using the reinforced ones or with suturing around, like ligating around the staple line afterwards? Right.
No, great question. There's a lot of variation, again, across the country in terms of surgical technique. Some surgeons will use different staple leg length thicknesses and buttress some of the firings, not some of the firings. Sometimes they'll use bovine pericardium strips. Sometimes they'll use the seam guard, which is like a PDS-like buttressing material. The bottom line is we're not 100% sure whether the buttressing material is making a difference. It does seem to make a difference in terms of staple line bleeding rates being a little bit lower, at least as assessed by the surgeon at the time of surgery. The leak rates are so low that there's really not been a definitive study to say whether buttressing does or doesn't make a significant impact on staple line leak rate. And so for many of us, it's just sort of a practice that we have adopted and acquired through education, who trained us.
Mainly all the experience.
Yes.
Well, to move on, with the bypass, what would be between surgeons in practice the differences and how do you perform your bypasses? Right.
So with gastric bypass, there are basically three fundamental steps. There's the proximal pouch or proximal gastric formation, the Roux-Y formation, and then the creation of the gastrojejunectomy. And in general, again, different surgeons do them in different sequences. For me, I do the jejunectomy first. I will transect the jejunum 30 centimeters distal to the ligament of Treitz. Then the roux limb length varies for me depending on the BMI below or over 50. If it's under 50, I make a 75 centimeter roux limb. If it's over 50, I make a 150 centimeter roux limb. And then that roux limb we bring up, in my case, in a retrogastric orientation. Again, some surgeons make those limb lengths longer, sometimes up to 100 centimeter of a proximal jejunal segment or a biliopancreatic limb. And then the roux limb can vary from anywhere from 75 to 150 centimeters for a standard gastric bypass. The roux limb transition to the upper abdomen can be either anticolic or retrocolic. I would say the majority of surgeons in the United States now are using an anticolic technique, but many of us are still doing retrocolic, which was a very common choice back in the open gastric bypass era. The retrocolic passageway has the advantage of a shorter distance, less tension, in my opinion, on the gastrojejunostomy, and a little bit more flexibility in terms of the creation of the other limbs and not having to create such a long roux limb to reach up. When you get up to the gastrojejunostomy, you've created your proximal gastric pouch. Again, some variations there in terms of the shape and size of the proximal gastric pouch. Surgeons tend to not use very much greater curvature in the formation of the proximal gastric pouch and varying lengths of the lesser curvature. But in general, the volume of that proximal pouch is anywhere from 15 to 30 milliliters in size. And then the gastrojejunostomy formation, again, that's kind of the final variation. Some surgeons, like myself, use a circular stapled anastomosis with a 21 millimeter circular EEA stapler. Some use a linear stapled technique, and then others use a hand-sewn technique.
Yeah, you actually answered my next question about your retrocolic approach. So we'll move on to the closing of mesenteric defects that is so emphasized with bypasses. Could you explain the different locations where internal hernias can occur after a bypass, and what potential complications can arise if these defects are not adequately closed? Additionally, how can these complications be prevented?
Right. Well, back in the open era of gastric bypass surgery, there wasn't a whole lot of discussion because the internal hernia rate seemed quite low. But the potential internal hernia spots include the mesentery of the jejunojejunostomy. If you go retrocolic, you have the defect in the transverse mesocolon, so bowel can slip through that defect. And then the final defect is kind of posterior to the roux limb mesentery. That's called a Peterson defect. Again, when laparoscopic gastric bypass became a thing in around 2001, 2002, one of the initial academic centers that was doing laparoscopic bariatric surgery presented a paper of a 6% incidence of internal hernia in the first year after gastric bypass in their patient population, predominantly through that transverse mesocolon defect. And they proposed and initiated kind of the switch to the anticolic methodology. By that point in my own personal career, I'd had about 100 gastric bypasses under my belt laparoscopically, and I only had a 1% incidence of internal hernia, so I stayed with the retrocolic method. But that is kind of the big dichotomy and reason why people are choosing different methods. It turns out, long-term for us in our methodology, the incidence of internal hernia in that method of construction is only about 3.5% at 7 years, similar to what anticolic roux limb Peterson hernia defect rates are.
Now let's talk about the post-op progress of the patients. We use here the ERAS pathway that is recommended with multimodal pain control, including some regional analgesia. Could you discuss the benefits of this approach to traditional methods and why NSAIDs should or are avoided in bariatric patients?
Right. So for many years, we kind of adapted from what we were doing with open bariatric surgery. So all the patients had PCAs, and we didn't start them on a diet until post-op day one. When I first started doing gastric bypasses at this hospital in 1997, I was putting NG tubes in everybody before I took them out the next day. But gradually we found that the small bowel motility really recovers quite rapidly, and so people can start on oral intake quite a bit more sooner than what we were thinking in the past. About 4 years ago, we participated in a multi-center quality improvement project to try to reduce narcotic utilization with this multimodal form of analgesia. So we give all these patients transverse abdominis plane blocks. They get narcotic sparing anesthetic methodology. We use Presidex and magnesium to reduce their narcotic use intraoperatively. And then postoperatively, we use predominantly oral pain medication, Tylenol, muscle relaxants, short-term Celebrex, and hyoscyamus, in addition to oral narcotics such as oxycodone, to try to get them through that postoperative phase. And that has really shortened up our length of stay to now under 2 days. About 2/3 of our folks go home after just one night in the hospital. In regard to the NSAID use and risk, that's a long-term concern. NSAIDs increase, obviously, the incidence of ulceration, and gastric bypass patients in particular are susceptible to increased stomal ulcer rates, around 15 to 20% lifetime for patients. And so we really preach to these folks that they need to get off of NSAIDs by the time they do their surgery. Even patients that have a bad, osteoarthritis that are taking quite a bit of NSAIDs, one thing we can tell them is that osteoarthritis pain gets a lot better with the weight loss, even fairly quickly after surgery. And so many folks who are using regular NSAIDs can get off of them after their gastric bypass surgery, and even within a month or two find that the knee pain, hip pain, ankle pain is quite a bit less than what they experienced prior to surgery.
Yeah, I imagine with all the weight loss helping their joints feel better. You touched there on the diet. Nowadays, I know we start our patients in clear liquids pretty much right after they wake up, as soon as they are with it enough. So what are the key milestones of progression of the diet, and what role does micronutrient supplementation play in the early post-op period?
Right. So we get folks started even as soon as they wake up, an hour or two after surgery. We're giving them liquids to drink, to take Tylenol and their oxycodone tablets, et cetera. So we really get going with that quickly. We can see that the bowel motility is sufficient that they do not typically have issues with nausea and vomiting, other than the ones that are typically seen with anesthetic within the first 24 hours. But most folks tolerate that liquid diet well. What we do initially is we put them on no added sugar clear liquids that first day. And then the next day we add in some non-clear liquids such as skim milk and protein drinks and cream soups. And those are the type of liquids that we have folks on that first week after surgery. We typically send the patients home on that liquid diet on post-op day 1 or 2. We don't wait for a bowel movement to occur. Really, we're not really perturbing the colon here, and we're not expecting a whole lot of bowel movements to occur, but we're not really worried about that because they're only drinking liquids that first week. And then they come back in clinic in person that first week. We get vital sign measurements, et cetera, determine their tolerance to the liquid diet. And typically at that point, we'll advance to pureed food, or basically level 1 or 2 baby food for a couple weeks, no chunks, to, again, initiate their solid food intake. And then after that, 2 weeks of soft food, which is typically cooked vegetables and ground meats and fish for the next 2 weeks. And then about 5 weeks out from surgery, we initiate a regular diet. So at that point, they're eating salad and uncooked vegetables and other types of meats as well. In terms of micronutrient deficiencies, these patients are potentially susceptible to B12 deficiency, folate deficiency, calcium deficiency, iron deficiency. So we get all these folks initiated on vitamin supplementation. Typically right now we're starting that on post-op day 5 at home and continuing that the rest of their life. The current recommendations from the ASMBS are to take 2 adult daily multivitamins plus 500 micrograms of vitamin B12 on a daily basis, plus 1,200 to 1,500 milligrams of calcium, plus typically vitamin D, because a high percentage of these folks are low in vitamin D. If they're a menstruating woman, we also put them on iron supplementation. This is true for both bypass and sleeve patients. I think some people misunderstand that sleeve patients are not as susceptible to vitamin deficiencies. They certainly can get them. In fact, there's about a 15 to 25% incidence of vitamin B12 deficiency among sleeve patients if they're not supplemented. So that's what we're really watching for. We have them come back on an annual basis and get those labs checked. And if we're having a lot of issues with troubles with nausea and vomiting, we'll check that earlier. And that's one of the things we really watch out from in terms of a micronutrient deficiency early on after gastric bypass or sleeve surgery.
We hope you enjoyed this installment of the Washington Manual of Surgery podcast. Stay tuned for part 2 of this episode to learn more about short and long-term complications associated with bariatric operations. We are Drs. Paul Wise
and Jeff Blatnick,
senior editors of the Washington Manual of Surgery. We'd like to thank the residents and faculty of the Department of Surgery at Washington University Medicine, and we'd especially like to thank our associate editors for this edition, Drs. Catherine Caldwell, Ina Chen, Bradley Kushner, Martha Bucky McGilvray, and Jorge Zarate Rodriguez.
We hope that you enjoyed this episode of the Washington Manual of Surgery podcast. For more comprehensive information in a brief outline format, check out the print and digital version of the Washington Manual of Surgery, published by Wolters Kluwer Health and Lippincott Williams and Wilkins. Please search online for the Washington Manual of Surgery 9th edition to purchase your copy of the manual.
To learn more about the educational opportunities available in the Department of Surgery, please search General Surgery Residency at Washington University School of Medicine in St. Louis.